Well, good morning, everybody, and welcome to today's board meeting for the Care Quality Commission. This is my second board meeting. I'm the chair, Ian Dilks, and we are joined by all of my board colleagues. We do have apologies from our legal advisor, Rebecca Lloyd-Jones, who's on extended jury service, but we wish her well there, and I'm sure that we'll be able to cope without her. This is, as you know, a virtual meeting. We've done that given what seemed to be a relatively thin agenda and the fact that a number of our directors now have to commute very long ways to physical meetings, so this seemed more efficient. But I would say that we're not intending that we will continue virtual meetings, and the intention is that in future we will aim to do everything by way of physical meetings. And I'll touch on that again in a moment. In addition to the board, I'm pleased to welcome Diane Horsley, who is this month's Equality Network representative. She's from our Gender Equality Network, so Diane, welcome. I haven't received any declarations of conflicts of interest, so I believe there are none to note. Before I hand on to the formal business, there are just a couple of other things I thought I would mention. The first is that, as was publicly announced recently, Robert Francis will, in a few months' time, stand down as chair of Health Watch England, and we also have some other NEDs coming towards the end of her tenure. So, appointment of NEDs is a ministerial responsibility handled by the department, and not by me or other members of the board. But we are working with them, and they will be probably in June putting out advertisements for non-executive board members, including the successor to Robert as chair of Health Watch England. So that will be public sometime in June, just for your information. The second thing is that regular watchers or people reading our minutes will know that in December of last year, the board received a report from an external company doing an independent evaluation of the board's effectiveness. And it was suggested at that time that consideration of the report could usefully await the arrival of the new chair, which turned out to be me. Board members and members of the executive have been, over the last few weeks, considering the content of that report. One of the conclusions that we have reached is that we agreed with the report's recommendation that we needed to allow more time for strategic discussions, as well as increased focus on monitoring of our delivery against the new strategy and our responsibilities generally. It was suggested that monthly board meetings was probably too frequent. So we are likely to move to a reduced frequency of meetings, albeit potentially slightly longer meetings. And that would bring us in line, just to be clear, with other arm's length bodies, most of whom tend to meet about 6 times a year, every other meeting. We're not going to make change immediately. We will, once we've made final decisions, communicate to everybody so you know what is happening. But I just thought I would mention that in advance so people are aware. I want to give you absolute assurance that to the extent that that means there will be less public meetings in a year, that we are not in any way intending that should reduce the transparency of the organisation. Quite to the contrary, we are going to carry out a review of the communication with the public at large, the people that we represent, to see whether or not everything is being done the most effective way. Public board meetings are a very important part of the way we are transparent in what we do, but they're certainly not the only part. And I think now is a good time to look at our overall approach to transparency. But the assurance is that whatever follows will will be less, and it might be more. And then I've touched on one response to the board effectiveness review, just to say that once we've finished our conclusions, we will bring it back to the public board sometime later in the year so people can see how the board has responded to the recommendations. We don't know exactly when that will be, but it will be certainly before the end of this year, probably sometime in the autumn once we've reached the final conclusions. Well, thank you very much indeed. Let's move on to the formal business. We have the minutes of the meeting held on the 23rd of March. I haven't received any comments on those, but could I ask my colleagues if we can approve those as a true and fair record.
Yes.
I'm taking your assent. Thank you very much indeed. There is a matters arising log. In fact, there is only one item on it. And Mark, it was down for you to report on cybersecurity in the wider system. Do you want to comment now, or do you want to pick that up in your report later on?
I'll pick that up later on, Ian, if that's okay.
In that case, let's move to the executive team's report. We had your usual written document, so thank you very much indeed for that. Ian, perhaps I could turn to you now and ask you to pick up the first few points.
Thanks, Ian, and good morning, everybody. So I think we can take my section of the report as written, but I think it'd be fair to say that the most significant thing since the last board is the royal assent to the Health and Care Bill. It's now become the Health and Care Act. And arguably it's the largest extension to our powers in a decade. It gives us the ability to use our perspective right across the health and care system much more effectively, and it will enable us, I think, to have a bigger impact in a range of different areas, but particularly in areas such as health inequalities, where we know that has been a challenge and has been particularly stark during the COVID period. I've included some headline urgent and emergency care figures. They remain a significant concern for us. And whilst there are some improving areas, we know that from talking to senior health leaders, that flow across systems, and we've talked about flow a number of times in the past, that flow across systems, and particularly the inclusion of social care and making sure that flow into social care services, that remains a major problem. Access rather, I should say, to social care continues to be a challenge in a number of areas, and to a large extent is driven by the inability to recruit carers, and that varies enormously from geography to geography, which again I think is an important thing to note when considering national figures. We will, of course, continue to use our convening power to bring a range of national leaders together to look for solutions, albeit that I think we do need to recognise that this is a complex and multifaceted issue, and frankly there are no simple solutions, and equally there is no one single entity that can solve all of these problems. Before I hand over to colleagues, just one final thing that I just wanted to raise, which was around the COVID-19 inquiry. Board members will remember that the Baroness Hallett has been chosen to chair the UK COVID-19 public inquiry. Baroness Hallett has submitted her recommendations to the Prime Minister on the terms of reference for this inquiry. And this follows a 4-week consultation period and a consideration of over 20,000 written responses and feedback at engagement events right across the country, including meeting over 150 people who were bereaved due to the COVID-19 pandemic, and representatives from 145 organisations from a range of sectors, including health, social care, education and business. And in conclusion, Baroness Hallett has recommended expanding the terms of reference in a number of areas of note for us. They include mental health, explicit inclusion of general practice, and care provided in the home as distinct to care provided in residential care homes. And Baroness Hallett has also recommended a reframing of the terms of reference, ensuring the unequal impacts of the pandemic run throughout the inquiry's work. And I think we would be very supportive of those changes to the terms of reference. We of course remain very committed as an organisation to cooperating fully with the inquiry when it commences its work, and we will of course continue to do that, and we will keep board colleagues up to date as the inquiry progresses. And that's all I wanted to say at this point. I'm open for questions before I hand on.
Okay, thank you. Any questions from my colleagues of Ian's report or comments? Robert.
Thank you, Ian. My question was about urgent and emergency care. I'm really my sense is that the position is now worse than it's ever been, but I'd like confirmation of that if we can give it, and accepting that actually it's an extremely complex subject as to how you solve this. I would comment that it has always been a complex subject, and the awareness that there are problems at the back door as well as before the front door have been discussed by people who know about it as long as I've been involved in healthcare. And what concerns me is that despite the fact that those problems are identified, we seem to have made very little progress in sorting them out. But having said that, I'm not sure, but I wonder if you are, as to what, apart from repeating what we've said before, CQC can do about this. And I wonder to what extent the use of our forthcoming duties with regard to ICSs may be of help in this regard.
Yes, I think I'll bring Rosie in a second. I know she wants to just come in and support that. But I mean, I think we're doing a number of things on a daily basis. Senior colleagues are talking to senior colleagues in both social care organisations, as well as talking to colleagues in NHS England, as well as leaders within systems. Only next week we've convened a major event bringing together a range of partners from rural colleges through to individual providers to talk about this issue and to look for practical solutions.
Which I'm
Sorry, which of course, yes, of course. Of course, I'd forgotten that. Yes, you're right. You are chairing. So of course, so I think we'll be using our convening power. I think very powerfully, and I think we do recognise the role that we have to convene groups of organisations and groups of people together in that way. But I think the other thing that we are continuing to do is to gather evidence so that we can have evidence-based conversations. Because I think you're right. The basic point is, yes, we all have known that this is a problem in the past, but evidencing exactly what's happening and evidencing successful solutions and solutions that work in some parts of the country and maybe don't work quite so well in other parts of the country is an important part of all of this. So I think we are doing what we can, and we continue to do what we can. But I think the ICS does give us this opportunity, I think, to talk more overtly than perhaps we've ever done before, and also gives us an opportunity to collect more evidence and more insight. And certainly when we've been talking to ICS leaders, the thing that does I think get them excited is the ability for us to benchmark and share data and information in a much more structured way than perhaps has been the case in the past. Rosie, I know you want to jump in on this as well.
Yeah, thank you. And Robert, I think you're absolutely right. This is a complex area, and it involves all of the different parts across the system working in their local communities to be able to deliver care. And it also requires really good communication with the public to understand that how to access services and how to use those services, because a lot of what we hear from the public is it's very confusing to know where to go in local areas. Often they don't know, different opening times of different services, different ways of working, and a whole variety of factors mean that sometimes it's quite complicated to work out, which service to use for what problem, and they end up in the wrong place as a result through no fault of their own. I personally think we need a much more proactive model of care. I think if we continue just to focus on the end of the pathway, of the urgent and emergency care pathway, we will never make the progress that we need. A significant proportion of people who end up in the urgent and emergency care pathway are people with long-term conditions, multiple complex needs, and actually we need to be looking at personalised care planning. We need to be looking at better advanced care planning and having a much more proactive model of care, so people are managed in a much more coordinated and integrated way. And I have no doubt that through the time we're doing integrated care system reviews, urgent and emergency care will be a key theme that we will want to look at. And we need faster development of new models of care and acceleration in the pace around these new models of care, much more focused on the out of hospital care models, working across community services, primary care in its broadest sense, and looking at kind of how we involve pharmacies oral health services and optometrists in these pathways, as well as GPs and social care. So I think there is a lot to be done, but it will absolutely be a focus of the integrated care systems. Just in the short term, my final point is that we will be looking at publishing, following the event you're kindly chairing for us next week, we will be publishing a report to kind of build on the work we've been doing with Patient First in emergency departments to kind of give that best practice and that view of what we see that is working across those systems, so that all systems will have that available to them to be able to make changes in advance of this coming winter.
Thank you.
Thanks, Rosie. Sally, you had a question.
I do, thank you. I may be preempting what Chris is going to say shortly, but I'm really interested in what Ian said about our convening role. And I wanted to ask about maternity services. So we are leading a summit, aren't we, later in terms of bringing more people together, just like we are on urgent and emergency care. And we did talk at the last board quite extensively after the Ockenden review had been published about how we would continue to focus on maternity services. So I just wondered if Ian or Chris could say something more about that, and apologies if I've jumped the gun, Chris.
I was going to come to it later. I'm happy to do it now or later, whatever you prefer, Ian.
Why don't you pick it up now?
Sure. So you're absolutely right, Sally. We talked about continuing our focus on maternity services. We've actually been speaking to a number of parliamentarians, as well as in the sort of setup of the review. You'll know post Ockenden there's been a number of conversations about why there hasn't been the progress. And in fact, if you go back, we started talking about maternity services needing to improve in 2017. So this is a long-standing concern that we have. We did an end of programme inspection in 2017. We produced a report called Getting Safer Faster. What was clear then, and what the feedback we've had since, particularly from frontline staff, is that this is a cultural issue as much as it is an operational issue. So the roundtable we're bringing together next week will focus on groups of staff who work at the front line of care. And what we've tried to do is to help understand why services in these areas are not improving, and what are the cultural things that need to be unlocked in order to see the improvements in frontline care and maternity services that we've seen in other sectors. I'm really pleased to say we've got over 180 frontline staff who've not only just registered an interest, each one of them has written a small piece to talk about their experience and what they feel they can add to the round table. So these are not just people that they've just registered for responding to an email. They've actually given us some information about how they feel they can support services. Obviously, the frontline staff are an important part of this, as are people who use services and people who've experienced harm. The aim of the round table is to try to, as I say, to unlock some of the issues that are affecting the way services are delivered, talking to frontline staff, and then to use that alongside what we've got from the listening events from people who use services to have a very clear message back to organisations, ICSs and potentially national organisations about how we need to collectively support that. So the event next Tuesday is actually one of a series of events that will give us, I hope, first of all, a sense of what, because there are some organisations doing some really outstanding work here. So why are they unique in there? Because there are very few of them. Why are they doing that well? What lies behind their work? What are particularly the cultural issues as well as the technical issues about that? And how can we promote that both within individual services and also across services and across systems? I'm really pleased at the engagement we've had so far, both from families that represent people using services and also frontline staff. And my intention was to come back to board with an update about what we've seen, and we'll obviously publish the results in full anyway. But I want to come back to board with a sense of where we go next with this at the next board meeting, if that's okay. Does that help?
Really, yes.
Thanks very much, Chris. Any other questions for Ian? If not, Rosie, can we turn to you for a few things?
Yeah, certainly. We've talked about urgent and emergency care, so I won't go over that again. Just the board report, there is an item, just a brief update around what's happening in our community health services work. As we know, community services play a really key part in both the urgent and emergency care pathway and the management of people with long-term needs and conditions in the community, and they are a fundamental part of the whole health system. So just to raise the profile of what our teams are doing in that area. Just something not in the report, but something I wanted to just flag with the board is my concerns about the rising level of abuse we're seeing in general practice towards people working in practices from members of the public at the moment. Over the last 2 days, I've sadly heard about one practice that, because of the level of abuse their receptionist was getting, have had to stop people having face-to-face access in a reception area. And I've also heard about an arson attempt on 2 different practices here in Taunton. And I think, you know, clearly these are very unacceptable. We know that people are having challenges with access and concerns about getting care, but we also know that people working across primary care at the moment are working extremely hard and trying to meet those needs and demands. So any form of abuse is not acceptable towards any member of health or care staff. So I just wanted to raise that with the board and raise my concerns that that is happening, and we're offering support to those practices that are having problems at the moment. Thank you, Ian.
Well, thanks, Rosie, and I mean, shocking that it should happen, awful for the staff, and last but no means least, clearly massively counterproductive. So anything we can do to lend our weight to raising the profile and making clear how unacceptable it is and stopping it would be welcome, I am sure. Any questions for Rosie? No? Okay, thank you very much indeed, Rosie. Kate, you were going to talk to us about visiting.
Yeah, good morning all. So carrying on a theme of my updates for a number of recent boards, a brief update on visiting and a brief update on workforce. The visiting position remains the same. We are expecting care homes to be enabling visiting to happen. There are no longer government guidelines in place about how this should be working. We expect excellent infection prevention control, and we will continue to look at that on all of our inspections. I continue to have a handful of concerns coming to me each week from groups representing families where they are concerned that visiting isn't happening where it should be, and each one of those instances there'll be a conversation with a local inspector or an inspection manager to follow up and see whether we need to go and inspect those services. So it's still quite a hot topic in our sector, and we continue to benefit from the public flagging to us where they think that care homes aren't keeping up with what they should be doing around visiting. But it goes back to comments I've made on a number of occasions. Most care homes are facilitating visiting to happen as you would expect. And then on workforce, so we are just updating you again on some rolling data we've been capturing around high vacancy rates. The vacancy rates are still high, but they've kind of remained static now, so they're remaining at around 11.5%. Turnover rates continue to be very high, and we are tracking the number of care homes exiting the market, the kind of net reduction in beds, which is there's been a similar trend line around care homes that don't provide nursing exiting the market. So wanted to flag that to board. And just one other thing to say, thinking to Ian and Rosie's comments around urgent and emergency care. On Friday, ADAS, the Association of Directors of Adult Social Services, published a survey in which they talked about 506,000 people awaiting a social care assessment or awaiting a package of care. They talked about 61% of councils only assessing people where there are concerns about abuse or people needing to leave hospital in a timely way or having gone through reablement. But also, interestingly, they talked about 170,000 care hours in the first part of this calendar year not being delivered delivered. So people with assessed eligible needs who need to have their care delivered, that wasn't able to be delivered due to workforce challenges. So there isn't, we can't draw a direct correlation, but if you think about that significant pressure in social care, and then you think about people arriving in hospital or being not being able to leave hospital in a timely way, it just reminds us again how completely interconnected all of these components are as well. Thank you.
Thank you very much, Kate. Stephen, you had a question?
Yeah. Thank you, Kate. And the question is really a variant of Robert's earlier question, that particularly what you're flagging around workforce and capacity, supply capacity. These are sort of problems that you've been flagging to us for a long time, and they're deep-seated long-term issues. On the workforce one, yesterday's announcement that we now have the tightest labour market since records began, in terms of, there are more job vacancies than there are people looking for jobs, is likely only to make our workforce situation worse. There will be lots of attractive jobs out there in the labour market that people working in care may want to move to. So there's a risk factor in terms of the current state of the labour market for our workforce. And similarly, your data on supply suggests that kind of the market is not currently operating in a way that new entrants are coming in to more than replace the people who are choosing to exit. So kind of one question is Robert's group going to sort this out? It's another example of some long, deep-seated, really intractable problems that we keep noting. It's quite hard to know, well, what could we do about them? And kind of the convening power that you've been referring to, does that help us get together the people who might have some solutions to some of these things? The second question was really back to Rosie. When we talk about new models of care and the role of integrated care services, do we see ICS as being set up in a way that will give them the capacity and the resources to make sense of such big, wicked, long-term issues? Because there is no short-term fix for the workforce issues and the supply issues going on in care. Really, can we expect ICSs to sort this out for us? That's a big ask of ICSs. Are they being set up in a way that gives them a chance of doing that? Thanks.
Okay, so I think if I start, I think what our data can do is remind the system why they should care about all parts of the system. So we know that occupancy rates in care homes have been rumbling at around 80% for a large part of this pandemic. So there are beds in care homes, physically they're unavailable, but people can't, for example, leave a hospital bed to go into that care home bed because the care home can't get the staff to support it. So there's something about how we can use our data to very overtly remind the system that there is physical space which might be in the absolutely appropriate setting for people to move to, but they can't because of workforce. I think the government's white paper that published before Christmas has some good stuff in there around workforce in terms of care workers, around passportable qualifications, around an ambition to explore a care worker register, which I'm really interested in looking at how that may develop. And then finally, I think Rosie would say the same thing as well. So we are really excited about our role around integrated care systems in the ownership or the leadership they may play, or hopefully will play, in ensuring that there are place-based workforce plans that can offer people who come in at entry level, be it as a care worker or into a kind of health role, that can enable people to progress and have a kind of integrated career pathway where they can be stretched and learn new skills and be part of a kind of virtual health and social care team within a place. So there is some excitement and some opportunity we have around our role with integrated care systems about saying to them, how are you assured that there are comprehensive place-based integrated workforce plans that are providing those sorts of opportunities for people at at that level. I don't know, Rosie, before you answer Stephen's other question, whether that reflects what you would say about ICSs and workforce.
Yeah, certainly, because I think we are seeing some lovely examples, albeit small-scale examples, of where some ICSs are being really creative in terms of thinking about workforce and thinking about their pipeline, working with local kind of educational institutions, really maximising those opportunities to kind of train and develop local people and local teams, and also thinking about that flexible use of workforce across all of the different parts of the system, because I think unless there is a credible workforce plan where people are not just kind of robbing Peter to pay Paul, if you like, and taking different parts of like a paramedic to go and work in primary care, but then leaving the ambulance service short, for example. People need to be looking at that in totality and working out how they move people across the system in a very structured and sensible way. I think there is also something about culture in terms of workforce, so that we drive that culture that's going to want people will want to stay and work, that they can learn together. In terms of the other question, Stephen, that you had, I think ICSs no doubt have a challenge ahead of them, and I think that especially with the workforce challenges, with the financial pressures and the kind of situation at the moment, there's no doubt that ICSs will find this challenging. And there is a kind of massive difference in some of the maturity we're seeing across ICSs at the moment in terms of how they're thinking more broadly about the four aims of the ICS, particularly around inequalities, particularly around that fourth aim of social and economic kind of development. And I think the best ICSs will be the ones that really kind of use this as an opportunity to work with their local communities, to understand their population needs, to build and collaborate with not just people in the health and care sector, but with, you know, education, with people involved in jobs, with local businesses and local industries, to see how they can really drive those improvements forward. I think in terms of the way they need to work, they need to be collaborating. They need to be thinking about how are we creative, how are we bold, how are we really challenging the status quo in terms of how we've already always done things, because I think we know that the current ways of working are not delivering the care that we'd like to see for our patients. I don't think there's going to be huge amounts more money. I don't think there's going to be huge amounts more workforce around the corner. So we are going to need to see levels of innovation that we've not seen across health and care in the past, and really seen that rapidly. And the CQC, just for any ICSs listening out there, please come and talk to us about those innovations. We don't want to be a barrier to those. We want to enable those. And often we hear the reason that people say we can't do it is because of the CQC. That's not the case. We want to work with systems to be able to enable them. I think that there does need to be much more of a focus on inequalities if we are going to really kind of deal with those challenges. And I think there's going to be some very difficult questions for integrated care systems about things like how do they fund services to make sure that people who are subject to the worst inequalities actually get better care, so we can really start to change that model, that kind of inverse care law that we see. So I think it will be very challenging. I think there is that opportunity, but it's going to require very different ways of working than we've seen to date.
But with a big prize, Rosie. So, Ian, if you wanted to comment.
Thank you. Just to build on the comments of Kate and Rosie, and to answer sort of Stephen's question, which I think is a really good point, is that at the moment, if you think of the reason workforce is a particular challenge in social care is because the jobs are paid at the lower end of the pay scale. The relative success of other industries, notably hospitality, and the inclination to holiday in this country rather than holiday abroad, is making the situation worse. And I guess in times past, there's been a sense that there were 14,000 registered 14,000 social care enterprises. There was 14,000 responses to the workforce problem. What ICSs have the potential to do is give 42 responses to a problem that was otherwise 14,000. One could argue though that there's a broader strategic question for I guess government, is the degree to which social care is seen as a piece of critical national infrastructure. and if it is, what is the single national stance around workforce in social care? I think the same argument probably applies to the digital component in digital dimension of social care and cybersecurity and so forth. But certainly in terms of workforce, 42 versions of response is better than 14,000 responses, but probably a one response is even better. So the question, I guess, is how do you cluster the different ICSs together in order to have a much smaller number of responses? And I think we potentially have a role to play there, where we can start to bring ICSs together and start to point out similarities of demography and local challenge. And so I think there is definitely a role for us to play in that area. And Rosie and I are sort of on a bit of a sort of virtual roadshow to meet many ICS leaders, and it is striking that some of them will naturally group together, and I think that could lead to some really important innovation in the way that Rosie was describing. Thanks, Ian.
Okay, thanks. I think that was the end of the comments, so thank you very much indeed. Tyson.
Thank you, Ian. I don't have much to add to my written report. I think it's fair to say that the performance we saw in April was more or less as predicted and as I trailed at the last board, and for the reasons that I set out then and I set out now. I think particularly the increase in the tendency to do more complex inspections in adult social care than we had done over January and February. The only other point I was going to make is that now that we've come together as an operations group, my senior team and I are very focused on removing barriers to performance for our teams. And I think by having a bigger group with all of the operations together, there are certain economies of scale we can have when it comes to trying to drive improvement. And a couple of examples I would give would be around taking a different approach to the way that we deploy specialist advisors and also bank inspectors, which can be a big issue for some of our inspectors at a local level, and also whether there are different and more innovative ways we can look at for give feedback on care or dealing with inquiries. So just part of an ongoing rhythm of how we will continue to look at ways of removing the barriers to performance that may be in place for our teams at the moment. But that's all I was going to say. Thanks, Ian.
Okay, thanks, Tyson. Any questions for Tyson from my colleagues? If not, we'll carry on. Kirsty, you just had one thing you were going to comment on.
Yes, just to bring to people's attention the Public Bodies Review Programme, which has been in the media recently, is a Cabinet Office initiative looking at ALBs and NDPBs of departments. We have recently received a letter from the Perm Secretary at the department saying that we will be working more closely with them to look at what that means for us as CQC. And we will keep you updated as that develops.
Okay. Thanks very much, Kirsty. I mean, you say this is a government-led review. Not much, having flagged it, not much more we can say at this stage. Mark.
Hello. I think on cyber, we've got no significant security issues to report from a CQC perspective. We are aware and have been made aware of a new ransomware threat that's in circulation, which is called Shimok, that compromises remote access accounts. There is some detailed guidance for organisations on how to protect against this. And I'm pleased to say that we can confirm we comply with all of those recommendations with our improvement work that we've completed already. Ian, you asked me the question about the wider health and social care cyber position earlier on, and we've consulted with colleagues across Department of Health and Social Care and NHSX, and I think the consensus is that there is. We're currently in a 3-year cycle of investment around cyber, which starts this year to improve cyber protection services across all of health and social care services, which is based around trying to reduce the risk of a successful cyber attack. And indeed, if you look back over the last years since 2016. There's been around 300 million invested, but the sheer size and scale of the sector means that there's a lot of work to do, and so there's still a significant amount of improvement that needs to be made. I think in addition to that work that's ongoing, there's also readiness being made to improve cyber resilience across the sector, to work to mitigate the impact should there be a successful cyber attack, which includes things like dry run cyber exercises and ensuring that all providers have got effective backup systems in place. I think for us that we've got a role as a regulator to play in supporting that improvement, in highlighting areas that there are areas that need improvement, and also providing an evidence base that supports what the digital and cyber maturity levels are across the system.
Yeah.
Thank you.
Thanks so much indeed, Mark. Any other questions for Mark? I mean, if not, then thank you very much, Mark. Just concluding the executive team's report, Chris, a couple of things for you, please.
Yes, so I've talked about the maternity service. I just wanted to flag one thing that wasn't in the report because it's subject to a go, no-go decision after the board papers were submitted, which is the update to the CQC website. This is a service that's used by thousands of people every day to access information about how services are performing. And I'm delighted to say thanks to Mark's colleagues and colleagues from my team, we've made some significant improvements to the way the website operates. For the first time ever, it will adapt to phone, and as you know, more people than ever are accessing their devices on non sort of PC systems. We've seen in the first week an 18% rise in the number of people accessing our sites on the phone, which is dramatic. The other things that we've made improvements to are our accessibility of the site more generally for all groups of staff, and we now fully comply with the WCAG website content accessibility guidelines set out by DHSE. So I just wanted to highlight that's happened. There are some other simple changes that we've made, so people can now compare sites with each other. So if you're looking to access a particular service, you can compare and contrast one service with another. There are improvements to email alerts, and there are almost always improvements to the way providers share their information with us. So I'm delighted by this. It is the first in a number of changes that we want to make to our engagement with both people who use services and providers, but it's an important and a useful first step. So I just wanted to bring that to colleagues' attention.
Yeah, thanks very much, Chris. I mean, it is still work in progress, but for anyone listening who hasn't looked, it is a major step forward. So thanks to, please pass on our thanks to everyone involved. And although it's not quite the openness point I raised earlier, I mean, I think it's a good example of how we recognise that we our responsibilities are to the British public using services, and this is a significant step forward in the way they can use what we do. So thank you. Any other questions for Chris? Well, if not, that concludes the executive team report. Let's move on to the next item, which is the corporate performance report. Now, I think we're going to be joined here by Chris Usher, who's our Director of Finance. Hopefully you're on the line. Chris, over to you.
Yeah, thanks, Ian. So as you said, this is our performance report, and it is for the year 21-22, which is obviously closed. We've included a year at a glance in the pack, so pages 46 to 48 in board's pack. I don't propose to go through this in each line by line, but hopefully illustrates what we've managed to deliver across the year and give some good information around that delivery. In terms of actual business plan performance, I'll just pull out some of the highlights and key points, and then open it out for questions of board. So in terms of our objective to analyse data we capture to identify, to interpret it to identify risk. In terms of managing risk to people, we've carried out monitoring calls and inspection activity with just under 30% of registered providers in the year. This is on slide 4 in people's decks. Alongside this, we also published statements regarding Band 1 services, as well as received safeguarding alerts, whistleblowing and complaints. Taking all that into account means that that 75% of registered locations have had some form of regulatory contact with us across the financial year. I've mentioned the short statements we publish. It's important that as we undertake quality assurance inspections to test our approach and findings. Slide 5 shows that we've undertaken 243 of these quality assurance inspections across the year. The vast majority are coming out as good or outstanding, which assures our approach. However, it's vital that we gain this feedback to test and learn on our approach. It also shows we've undertaken just over 10,000 inspections in response to risk. 60% of these were rated as requires improvement or inadequate. In terms of registration, which is on slide 6, it shows we've improved our timeliness in year, with time taken to process simple applications reducing by 4.7% and normal applications by 8.1%. However, both areas and the complex applications, which saw a slight increase, were below the target for the year, which we set, which was a 15% reduction. In responding to concerns, safeguard and whistleblowing, we aimed this year to increase the volume of people giving us feedback. And in year, we've had 52% increase to give feedback on care from people, which is on slide 7. This is incredibly insightful information. And what we do with this depends on the information received. It is worth noting some of this is positive, some is negative, but our responses can range from contacting the provider, being used as intelligence for inspection planning, or in some cases, a referral to safeguarding adults, local authority teams. So there's a significant increase in give feedback on care year on year. Some other areas to pull out. So slide 10 shows that major publications we've issued have all been delivered on time, collectively with 42,000 views. And on slide 12, you can see across our transformation, all current milestones were either completed or on track where they run across financial years where we'd expect them to be. In terms of managing our people and resources, the deck includes various people, data and metrics slides 14 to 19, in addition to our business plan measures. In terms of actual measures for the year, 57% of colleagues would recommend CQC as a good place to work. This was down from 67%. And 66% of colleagues think CQC supports their well-being, which is up from 60%. We continue to pursue a more diverse representation across our workforce. And we see that Black and minority ethnic colleagues represent 14% of our workforce, and colleagues declaring a disability represent 9% of our workforce. In year, one of the things we really aim to do is ensure that all recruitment panels have an independent panel member for senior recruitment, and we've done this in 100% of instances. And finally, in terms of our finances, at the end of the year, our revenue budget was underspent by 9.9 million, which is 4.2%. Our underspend is across pay and non-pay, and largely due to adapted ways of working as a result of the pandemic. For example, significant reduced travel costs in year. Our capital budget was ended the year 0.9 million underspent, which is 6%. So that's it from me, Ian. I'll open out for comments and questions. Thanks.
Okay, thank you, Chris. I have some questions, but let me start with my colleagues. Mark Saxton.
Thank you, Chairman. Chris, thanks again for another very thorough performance report. Page 2, the business plan overview. I mean, we have several activities there that are either on hold or in development. And as we know, those are two different things, so it's slightly unclear. But I suppose my concern is if something's on hold for a very long time, then it's inevitably going to fall into a red category. So I just wonder whether you have any view on whether we should try to split that out as the difference between being on hold and being on and on in development. In terms of the people charts, it's a nice new first page of that chart, just sort of showing the RAG rating of the KPIs that we look at.
for people. So I was pleased to see that. Looking at the absence rates, sickness and well-being, it's slightly concerning to see grades B and F running at 17.7 and 16.8%. Stress, absence for stress versus our corporate percentage of our absence rate for stress being 11%. But that's something I'll take up with Jill. In terms of employee feedback, it's still people joining us and not inputting their data onto the ESR, which only goes to compound the fact that we don't have full accuracy on our data. But you mentioned quite clearly our performance in terms of our recruitment of ethnicity, our ethnic background employees, and it was very encouraging to see that at 19.5% of starters coming from an ethnic background. And finally, could I just say on the turnover and movements in the charts, I'd really feel it would be good for us to be looking at promotions, making ups or acting ups and secondments across both the disability and ethnic groups in our organisation. But I think that most probably falls more into Mark's area, Mark Chambers' area in terms of sponsorship of D&I. But I just make that point that I think that, it would be good to be looking at that. But thanks for a very thorough report. I thought there was some very good data in it.
Chris or Ian, I don't know if you want to respond to any of those. Most were observations, perhaps rather than questions, but then I'll go to other questions afterwards.
Yeah, I mean, all of that information is something that we look at from an executive point of view. So we can take that away and look at additional things to add into the report. That's fine.
Thanks, Ian. Sally.
Thank you, and thanks for the comprehensive report. It's always good to review at the end of a financial year. I just wanted to pick up on the inspection activity or inspection and monitoring activity, because it's kind of buried in there, Chris, but we've seen a substantial increase in all of the activity that CQC has delivered. And I just think it's worth pausing at that point to say, I think there have been press articles or articles written to suggest that CQC weren't quite monitoring or regulating in as much detail or to as many providers as possible. And these statistics would not bear that out. So I think it's perhaps just worth Ian or someone explaining, perhaps for members of the public who don't quite understand that crossing the threshold isn't the only thing that we do, quite how our activity has ramped up and what our staff have been able to deliver. Thank you.
Ian, do you want me to take that?
Yeah, could you? Thanks.
I mean, I think Sally, it's a good question, Sally. I think your point is well made. That right at the beginning of the pandemic, we made a conscious decision as a board to move to more of a risk-based a risk-based stance, and we stopped doing routine inspections. And I think, as you rightly say, the press articles were largely driven by that sense that that we needed to be continuing to do some kind of routine-based inspection. But as Chris identified, there's been a significant increase in give feedback on care, and that has been particularly pronounced in some sectors. Particularly the feedback we've had around general practice there's been an even bigger increase as a percentage. And that's meant that we have continued to develop our approach. So we've had a range of different, quite specialised reviews sometimes. So we've done things like infection prevention and control reviews, where we've particularly focused on a small number of questions, but go and see a lot of people. We've also developed what we call our direct monitoring approach, which is it's a sort of like a reconnaissance approach, if you will, where we are making structured telephone calls to providers. Also, we're doing a structured review of the data that we hold on those providers, and we're blending those two things together. And if we then have further concerns that is then triggering an on-site inspection, We've also been doing some work on looking quite deeply at the way in which we do ratings-based inspections. So we've done a lot more in the way of focused inspections, moved away from, if you like, the larger long-form ratings inspections that we've been doing. So a range of different responsive approaches that are focused on risk, focused on trying to cover as much ground as we can, given the complexities of the COVID situation that we've been in. And of course, I think as we sat here, a year ago, we were all hoping that COVID was very much on the wane. And I think we have, this data does very much reflect another very COVID-focused year, which we all hoped we wouldn't be in. And of course, we've talked about our transformation approach, which will deliver again a very different and revised approach, but it will be very much building on the lessons we've learned over the last couple of years around remote monitoring and ability to reach into GP systems and do remote clinical searches. Very much a focus on a deep assessment of real risk and the things that are going on, and then respond to that risk appropriately. So I think we've tried to move away from these kind of big long form reports, but at the same time, I think the public should be absolutely assured that crossing the threshold will remain an absolute core part of what we do. But there are a number of other tools that we can use and we can deploy to make sure that we're discharging our overall duty to provide the public with assurance around health and care services. But thank you. Thanks for the question, Sally. Cheers.
Thank you.
Thanks, Ian. Stephen Marston, you had a question.
Thanks, Ian. I wanted to pick up, it's page 30 of the pack, which is the give feedback on care data. Firstly, it seems hugely positive, and congratulations that there's been such a rapid increase in the number of people using the system. Hugely powerful and important data on people's experience of different services. But it then kind of prompts, at least for me, a number of questions. Firstly, if this is both good experience and bad experience, this could be pointing in a number of different ways. It could be pointing up a greater level of risk, or it could be pointing up a greater level of satisfaction. Is it possible to disaggregate these data into positives and negatives? Because, as I say, they sort of point in very different ways in terms of the service performance. Second one is that massive increase between December and March. I'm assuming that's more down to your success, congratulations, in making people aware of this opportunity to give feedback than any measure of growth in underlying public concern about systems. But is there any way of kind of tracking that underlying concern level, which is different from your success in getting people to fill out a survey instrument? Final one, if I could, the biggest single increase is in primary medical services, which got me wondering whether this is kind of aligning with what Rosie particularly is hearing. Is this warning that there's a disproportionate level of concern going on in primary care compared with trends in other sectors? Is that what we're hearing from other sources? Thanks.
Ian, I don't know whether it might be easiest to pick it up, general comments, and ask others to add as necessary.
I think Chris and Tyson can probably come in on both of those topics.
Shall I? I'll kick off to say some board members will remember we changed the give feedback on care process now almost 2 years ago, and a lot of the changes that we've seen since are actually a function of the fact that we've got a give feedback on care service that works more for people who use services. So that's thing one. We've had a number of spikes where we've deliberately targeted groups of people to give their feedback over last for each year, and some of the increase reflects the fact that we've worked with Health Watch, we've worked with Age UK, we've worked with other organisations to target particular groups of people. In terms of the good and bad, often people provide both in an individual give feedback on care. So they may give some information which is positive or neutral, and some areas of concern. Because people are not the same thing as locations, they may give information about their community care experience, their secondary care experience, and possibly their adult social care experience. So they are giving their perspective, which I think is really helpful to us, not just in our regulation of locations and organisations, but our thinking about systems moving forward. So we can disaggregate it, and often it might relate to one or more different services when we do. Finally, on your point about primary care, I know Rosie will want to come in. I think that a significant proportion of that rise has been connected to access to primary care services over that time period. I think the post-pandemic pressure on primary care that we've seen is reflected in some of the information that we've seen in give feedback on care, and that's helped. The last thing I say is that the group that have been responsible for doing some of the monitoring activity have actually encouraged providers to gather that feedback themselves or from organisations across all sectors, and that's also helped in improving and maintaining the rise of give feedback and care in the last 6 months. Hope that helps, Stephen.
Tyson, do you wish to add to that?
Just a couple of things to add, Ian, if I may, to Stephen's question. One is to do with the volume, and Ian mentioned the direct monitoring approach that has really been ramping up over the last few months. Part of that approach, as the team prepare for the monitoring call, is to seek feedback on care from the provider that they're doing the call with whether that's a GP practice or an adult social care home, and we're seeing quite an increase in give feedback on care as a result of that, which I think is a really good thing. Clearly, you will have seen that the volumes have gone up considerably over the last few months, which has been an additional amount of work for the teams to deal with, and I'm really grateful to the teams for the professional way in which they've dealt with the feedback, because it's really important. And I alluded to it earlier, but we need to get, I think, smarter at how we triage the feedback, so that where we get feedback, we make sure the inspectors see it and that they are able to reflect it in the way that they view the provider, but particularly making sure that where risk is identified in feedback on care, that is also highlighted to the inspectors so they can take remedial action if they need to. So despite the volume of feedback on care, we are still taking the right action with it, and we'll make sure that our inspectors are always aware of what it says.
Thanks very much, Tyson. Diane Horsley, our network representative, joined us today. You have a question.
Yeah, again, it's on the give feedback on care. I noticed that when you look at the hospitals data on slide 7, there's two particular spikes, February and March 2021, and then again February and March of this year. But in between those times, it settles down into quite a regular pattern. Whereas, so I was just wondering, is the first spike down to targeted approach on give feedback on care, Chris, for that period, or is it possibly COVID? And because of the settling and it kind of having quite a consistently lower rate compared with the others, are there any plans for more targeted approaches to get more feedback on care from hospitals?
There are. So first of all, we look for people, not institutions. So we'll look for people, as I said before, they may work with or use a number of different organisations. So there are particular groups of people that we want to hear feedback from. Often the spikes relate to some of the activity that we do at the time of a big report coming out. So we may do some focused activity either in a geography or with a particular group of people. So, for example, recently we've done some work on maternity services in light of the work we're doing, and also on urgent emergency care. So that can often prompt spikes in feedback that we received. But our we are acutely aware of where we need to gather more feedback from particular groups of people, and a lot of the spikes working with our partners who represent people who use services in different areas are geared towards trying to make sure we are hearing from all parts of the community in all areas. So that as I say, the spikes often relate to some of the work that we do that preempts that. But my aim is that we can hear from all parts of the community to make sure we've got a really accurate picture of how people are receiving services.
Now, your question, Diane?
Yeah, that's brilliant. Thank you.
Chris, I had a number of questions myself, probably because I'm the newest member of the board. It's my first review of year end. Quite a number have been addressed by my colleagues, and I do particularly pick up on Mark Saxton's point about in the plan overview, distinguishing between what's in hold, that grey box of what's on hold. I think that would be very helpful. I had three other questions which I'll pose to Ian initially, but he may wish to ask others to do it, to comment further. One is on the registration. We had a target of reducing time. The good news is, despite the increase in volumes, that we have been successful to a degree, but not as successful as we would have hoped. And I just wondered if there's anything to be said about the barriers to making further progress. Were we just over optimistic, or is there a barrier that we can deal with? And I suppose that leads into whether we think we'll do it more next year. The second is, you commented on the reduction in travel costs. I mean, we've seen changed ways of working, which we would plan on being sustainable. We've also seen the impact of COVID, which is changing. And I just wondered if you could comment on how much of the reduction falls into each of those buckets. I don't need precision, but I suppose, again, behind that question is, what are we likely to see in the future, having achieved some sustainable reductions through different ways of working, but at the same time, now ability to do more inspections as we're out of COVID restrictions. And then my third question is around people. You did specifically comment on it, but there was a reduction in, I've forgotten the exact question, but people's views about CQC, and it's fallen from 67% to 57%. I just wondered if you could comment on why we think that happened and what actions are being taken. So three very different areas. So Ian, it might be easiest if you have any additional high-level comments, and then ask others to add if you think that's necessary. Thank you.
Sure. Thanks, Ian. I mean, in terms of registration, I think there's two areas just really to raise there. One is a straightforward recruitment one. We've done a lot of work in terms of leaning processes, making them more efficient. I think the team have done a really good job of doing that, and Kirsty can come and talk about detail if necessary in that area. I think we did see a big improvement. What we did see, particularly sort of around the Christmas time, is an increasing difficulty in recruitment, and so there are just simply fewer people. We're continuing to try and address that, as we are with recruitment more generally. And the second factor, which I think is relevant overall in terms of our overall rate of improvement, has been the prioritisation process that we've put in. We unapologetically were prioritising applications that were going to add additional capacity into the health and care system during the COVID period. So if you are approaching us looking to build a new care home and open a new service which was going to add some particular capacity in a particular area, we would prioritise that activity over perhaps services which perhaps were going to add direct COVID capacity. So we tried to make a triaging judgment quite early on, and that again I think has somewhat made some of the figures slightly odd looking in places where some applications are dealt with incredibly rapidly as a result of the work that we've done, and others take a disproportionately long time. So there's a bit of a range in places. So I think recruitment and prioritisation are probably the two registration points. In terms of sustainability of our overall cost base, it's something that we have continued to put work on more generally. I think change changed ways of working has made a difference in the short term. I think we have got services like the direct monitoring approach that I talked about earlier on, which does mean that we will be doing more work remotely. That said, though, I think we will continue to be travelling, and I suspect some of those travelling costs may come back, and as we do more travelling. The other thing that we do is use specialist advisors and experts by experience to accompany colleagues on inspection. And obviously, as we've been doing fewer long-form inspections, we've needed to use fewer of those colleagues and for less time. I think, however, having said that, though, I know Tyson and his team are looking at how we use specialist advisors, how we use experts by experience. Can we use them in the most effective way? And we have seen some success in that area. If I look at a good example of that would be our second opinion appointed doctors, where it's a service that we offer on behalf of the Department of Health and Social Care, and in that area we've managed to move to a service which is a lot more remotely delivered as a first point, as a first way of doing things, rather than the traditional approach of people travelling and often spending a significant amount of time on the payroll, as it were. So I think there are a number of examples where we've made changes. Some of them I think are sustainable, and some of them probably will start to come back as we move to a more in-person approach to things. And finally, the people point. I think I guess the short answer on the people point is well, there's probably two reasons. One is we are making significant numbers of changes, and we've talked at length about transformation, which again we know it causes people some uncertainty. But I think probably the single biggest reason is pay. We've talked a lot about pay, and we've noticed that particularly over the last couple of years, our pay has become increasingly uncompetitive in comparison to the places that we recruit from. We recruit traditionally from adult social care home managers, and from the NHS, and we're finding that we're increasingly uncompetitive in that area. So we are pulling together a business case to Treasury to look at our pay scheme in the broader sense, with a view to improving our pay scheme, because many board members will know that our pay scheme is linked to the civil service pay rise process, the civil service pay remit, even though we have a sort of a hybrid pay scheme in the sense that we have an NHS pension, but we have a CQC terms and conditions. But any pay rises are linked to the civil service pay remit, which is a slightly awkward combination of things, which we are looking to fix. And we'll be bringing forward a business case to our REMCO later on in this year, with a view to resolving that pay position, ideally before the end of this calendar year, if we possibly can. Although I think that will be largely dependent on progress through the Department of Health and Social Care, Cabinet Office, and so on. So I think that's probably they're probably the areas that I would look at as being the reasons why that particular number has decreased. Thanks, Ian.
Thank you very much, Ian. I had no more questions, and I don't see any others. So thank you very much, Ian and team, for that very helpful update. Let's move on to the next item then, which is the quarterly transformation portfolio update. Kirsty, I think you and Mark are going to pick this one up.
We are, yes, thanks. So I'll just kick off and I'll hand over to Mark to pick up a few other areas. I'm going to take the paper as read, but just draw out a few highlights for you. We are now at sort of year end, and I think it's just worth the opportunity just to have a little bit of a reflection on the year that we've had to date. We set out at the beginning of the year to deliver our interim operating model state 1, and I think we are in a really good place in terms of what we've achieved around that. And just a few of the highlights around that is we launched our digital and intelligence unit at the end of March, which was on track as we intended. That's the piece that's giving us our real insight capability and enabling us to really transform into that insight-driven regulator that we aspire to. We have appointed all of our senior leaders across our regulatory and operational functions as on time and as we intended. And we've also developed our new single assessment framework and the scoring that goes with that. And that's bringing all of our regulatory activity into one single assessment framework. So we're able to really take that end-to-end approach in terms of how we are going to regulate and really start to set out that as a codified piece of work. And it's been a huge piece of work. And I'm glad to say we've managed to do that within the year as well. We've done all this as intended on time and on budget, which I think is a fairly major achievement. And I would just like to take this opportunity to say thank you to everybody in the teams in CQC who have been working really, really hard over the last, well, not just last year, but the last couple of years to get this huge piece of work landed in such good order. That's the sort of early stages of our transformation. We're now starting to get really into the meat and bones of what we're doing, and our focus moving forwards is now on implementation, particularly as we start to roll out our new methodologies into our operations, and really start to look at how we can bring both the people changes, the system changes, and the regulatory changes together into a sort of coherent whole. What we are planning to do over the next month or so is to pilot and test our new methodology. We've done some work doing that in a sort of a virtual environment to sort of test out the functionality of the systems. And we're now looking to put that into place in a small way to test that in pilot stage, and then looking to roll that out. We're using a sort of early adopter approach, and then so that we can really test our activities, making sure it all hangs together and it works properly before we look to scale out that into across the rest of the organisation, with a view to landing that within this next financial year. We are working as well as part of that to look at how we implement our multidisciplinary teams. So this is moving away from our work where we're currently brigaded in specialist silos such as hospitals and primary medical services and adult social care, but moving into a more geographically based workforce with a multidisciplinary team approach. And we're looking at how we start to put that into place as well over the coming months. So I think in summary, a pretty good progress we've made, lots of work still to do and lots of difficult things still to come, but I think we've built some really good capabilities within the organisation now on delivering and managing our change, and I'm confident that as we move forward, our interim operating model states 2 and 3 will make good progress with that. So Mark, I don't know if there's anything particularly you wanted to pick up.
Well, just a little bit of extra detail on the technology, the data and insight pieces. So, in our regulatory platform work, we're on track for this, building up towards an autumn release of new digital services, and we'll start to roll those out with providers and for our internal colleagues who are managing registration and managing assessment and the publication of our new up-to-date ratings. And we'll be phasing some of those services in carefully with providers and with the public in the summer. And we've launched our new data and insight unit, so that an important part of that is the new enterprise data platform, and that aim of that is to build a new core repository of high quality data and tools. And we've completed the recruitment of our new senior team in data and insight, and the next 6 months will see us really mature and establish that unit to support us to become an insight driven organisation. And then just finally, in our finance transformation work, we've procured and onboarded a new implementation partner. We're nearing the completion of that design phase, and we've also completed the implementation of our new portfolio management tool and transitioning that now into regular business practice. Thank you.
Thanks very much, Mark. And to Kirsty for those. The good questions. Mark Saxton.
Thank you, Chairman. And Kirsty, thanks a lot for this report. A couple of observations around the people strategy update. I mean, really good to see the work rolling out on culture. This, as you know, came to ACGC and we were very supportive of it. And also good to hear about capability building. And I'm sure that you are demonstrating a lot of success stories there, because I think that would help us convince our people and reassure our people that we're traveling in the right direction. But can I ask a question about the really good news in here about, and congratulations on the rolling out of the regulatory and the operations leadership teams, and also the data and insight unit. So that's a really big step forward, and so well done to the whole team on that. But my question is, how are we capturing what went well in that process, and perhaps what was tricky in that process, so that we can learn from that and apply those learnings for future rollouts?
Yeah, so in response to that, Mark, I've just seen a draft report, which is basically what we've done at the end of IOM1 is we've done a whole lessons learned review piece of work, which is basically looking at what went well and what could have gone better, and making sure that we're taking that forward and applying that to sort of the next stages of our transformation. It's part of our sort of continuous learning approach. So we've got areas from across all of the portfolio, including some of the stuff around management of change and our people activities that we are feeding into that. So it's not quite complete yet, but once that's done, we'll be able to really look at that and then put some sort of actions against those, so that we're able to track that. And I suspect that might get picked up as part of our internal audit process going forward as well.
Thank you.
Thanks, Mark. Thanks, Kirsty. Any other questions for Kirsty or Mark? I have no questions, but again, I'm still the new boy here, but it did occur to me, we've made much of the transforming data and insight work, and it's clearly a strategic change in what we're doing. So it would be helpful, I think, on future reports if we could bring that alive and talk a little bit more about, give some examples maybe of how it's informed a different way of doing things. But certainly of interest to the board, and I think to members of public who may be listening as well. If there are no more questions on the portfolio update, thank you very much indeed for that. We have a couple of questions from the public to address, but just before I do that, I should come to any other business. Any of my colleagues wish to raise any other comment? I'm seeing shaking heads. Okay, thank you very much indeed. As you know, we do give members of the public an opportunity to submit questions in advance, and we do have a couple from Robin Pike. In fact, I'll take them separately. I'll read them out and then ask somebody to respond. The first question was, how will CQC regulate patient access to primary medical services when the GP contract changes in October? And Rosie, it's probably best if I could ask you to respond to that.
Yes, certainly. Thank you, Ian. And in terms of how we work on our methodology, the contractual changes which are looking at extended hours are not going to change what we do in terms of looking at the quality and safety. Access is something we've had a focus on throughout our methodology, through our responsive key question, and it's something that's very important. And we don't just look at access in terms of appointment availability and what is offered, but we also look at the appropriateness of the modality that appointments are offered in, and also how people who might find it difficult to access services are able to get access. So the contractual differences won't make any difference specifically in terms of our methodology, and we will still be wanting to make sure that people have good access to all primary care services, however long they're open for and whatever form they're open in.
Okay, thank you very much, Rosie. The other question, and I might take this one myself and then see if Ian or others wish to add, but the question was, how do we, CQC, find children and adolescent mental health services are performing following the COVID pandemic? We did give some thought to that. I mean, in our provider collaborative reviews last year, we did look at mental health of children and young people in a number of areas of England, 7, I think. That gave rise to a number of findings, including challenges in ensuring the availability of staff with the right skills. No surprise there. and recognition that health inequalities have been exacerbated by the pandemic, something that has clearly been on the board agenda even since I arrived and certainly before. Through the regulatory work that we do, we've identified a number of common themes. That includes an increased demand for continuity of inpatient services, touched on earlier, with more children and young people being referred, and challenges in children and young people being able to access the appropriate inpatient mental health care and treatment. Now, many of those existed pre the pandemic, they're not new. But while we know the inequalities people face have been exacerbated, I think it's too early to understand the full extent of the impact post-pandemic. And we are still, we'll be optimistic here, just coming out of the pandemic. I think the important thing to say is we do recognise we've a key role to play in regulating child and adolescent mental health services. But they're only one part of the wider services required to support children and young people to be safe and to live well. Our work to develop an approach on the ICSs, the review and regulation, will give us, I think this is pretty crucial, an opportunity to highlight issues faced by children, young people and their families. So thank you very much indeed for the question, and it's far-reaching, and we'll also therefore send a more detailed response to you following the meeting, but we did want to flag the fact that it had been raised, and that was our initial thoughts. I thought it was easiest if I responded to that, Mr. Pike, but Ian, I don't know if your colleagues wish to add anything.
I don't think so, other than just simply to loop back around to where we started. I made the point at the beginning of the meeting that the new health and care bill will give us probably the largest extension to our powers in the last decade, and I think Robin's question is very much one of how is the system working for children and young people, and I think whilst we can look at how individual providers are performing at the moment, our extension of powers gives us an ability to start to have a much more comprehensive view of that question than we can at the moment. So I think it's a good question, Robin, but I think we really won't be able to fully answer that question until we really get into the ICS work over the next few months. Thank you.
Okay, thanks very much, Ian. So those were the only questions we received. So can I just thank my board colleagues, thank those who may be listening in, and thanks, Diane, on behalf of the CQC networks for joining us today, and some good questions. I think on that, I'm going to formally close the meeting and the webcast, and the next meeting, just to confirm, will be streamed, but it will be the board meeting will be a physical meeting from our office in Stratford. Thank you.